neonatal lecture series. My name is Kitai, and while I'm not currently in Sydney, I'm really excited to introduce our speaker for today. He's none other, a lot of you would know him, is Dr. James SOTIROPOULOS. He's currently a PhD candidate with the University of Sydney and resident doctor in Australia. And a lot of you would know his work, which is focusing currently his PhD on applying next generation evidence synthesis and meta-analysis methods for neonatal resuscitation. And his work primarily focuses on oxygen use for neonatal resuscitation, but he's also involved in work on cord clamping for preterm birth, surfactant, and HIE. He currently holds a prestigious NHMRC postgraduate research scholarship and has been recognized nationally and internationally for research excellence with numerous awards. So in only a few research active years, we all know that he has been involved in many high-profile works that has influenced international treatment recommendations, achieved publications in JAMA Pediatrics, and has co-authored papers in The Lancet. So this morning, we're really excited to hear about how much oxygen is safe for preterm newborn infants in the first 10 minutes of life from the NetMotion study. So James will really walk us through his current study. And I'll just invite him to share and to actually talk to us this morning. Thank you. James, all yours.
Thank you, Kitai, for that very generous introduction. I'm just checking, you can see the full screen or just the slide?
Yes, actually it looks good. Yes, please go ahead.
Okay, hi everyone. Thank you for joining online today. My name is James SOTIROPOULOS. As Kitai said, I'm a current PhD student with the University of Sydney and a resident medical doctor based in Sydney, Australia. Today, I've got the opportunity to talk to you about my favourite topic, which is delivery room oxygen therapy for the resuscitation of preterm infants. I'll go through some of the recent evidence that's come out and what we can expect on this research question in the next couple of years. So hopefully by the end of my talk, all of your babies will look like this baby on the right, a very happy baby that's received just the right amount of oxygen, and they even get to go home with the oxygen cylinder as a souvenir because they loved their oxygen so much. To start with, I'll go over the history of how we've used oxygen in neonatal resuscitation over the last couple hundred years, as well as talk a little bit about the methods that we've used to address some of the difficulties on this question, namely individual participant data and network meta-analysis. The big ticket item is the results of the NetMotion study, which came out last year that some of you might be aware of, but we'll spend lots of time breaking those down and going through how those results can be interpreted in the context of current practice and what's going to happen moving forward from here. So oxygen was identified by a man named Joseph Priestley as an element in the late 1700s. And just 6 years later, people started using it to treat newborns that were born depressed, needing resuscitation. For the next couple hundred years, its use was widespread and it was used very liberally to treat all asphyxiated infants born during the 20th century where oxygen was available. But concurrently, kind of in the late 20th century, there was a growing evidence base concerning the harms of using too much oxygen. The concepts that arose from that body of work, you now might know as the concepts of oxidative stress. So taking a step back, we know that intrauterine development occurs in a relatively hypoxic environment where PaO2 is only 40 to 50, but rapidly in the first few minutes of life, increases in partial pressures of oxygen to normal levels above 70 cause a physiological level of oxidative stress, where oxygen-free radicals are required to kickstart body systems in the transitioning infant. But in asphyxiated infants who have depleted ATP and primary energy failure, reperfusing their ischemic tissues with high concentrations of oxygen can precipitate a toxic and paradoxical reperfusion injury where there's supersaturation of innate antioxidant defenses. And the excess amount of oxidative stress can cause tissue damage and irreversible tissue injury. So the results of this body of work led people to believe that using oxygen in an unrestricted way to these infants might be harmful. So clinical studies followed that body of preclinical work, and the most seminal study was the RESAIR-2 study published in 1998 by Ola Saugstad, which was a multi-center trial done internationally, randomizing term asphyxiated infants to either room air, so 21%, or 100% oxygen for the entire resuscitation period. They found that the odds ratio for death within the neonatal period was reduced. It was almost reduced in the room air group with an odds ratio of 0.67, and you can see with that confidence interval, it almost doesn't cross the line of no effect, but it just does. So there was a strong signal that there's a possible effect here, and a number of follow-up studies were done, and they were culminated in a systematic review and meta-analysis published in 2005 that had 1,300 infants, and they found a similar odds ratio to that initial ResAir study. But this time the confidence intervals didn't cross the line of no effect. So they concluded that a room air resuscitation for term or near-term infants was beneficial and reduced mortality. At the same time, there was a growing understanding of how the infant's oxygen saturation evolves over the first 10 minutes after birth. So pulse oximetry now is an additional vital sign, but was kind of creeping its way into the delivery room in the NICU around this time. And some very clever people put a lot of oxygen saturation probes on term, spontaneously breathing healthy infants, and they recorded what their oxygen saturations did over the first 10 minutes of life. And they found that it actually took about 6 or 7 minutes for oxygen saturations to reach normal levels, so around 90 or above. Based on this, it's now standard practice to adjust the concentration of oxygen to try and mimic this gradual evolution of SpO2 over the first 10 minutes of life. All of this evidence was really coming out in term and near-term infants. People were questioning whether this was generalizable to preterm infants, so lots of trials were done, but more than 10 randomized controlled trials were completed and there was still no definitive answer. The treatment recommendations had a lot of uncertainty, and those recommendations were therefore based on lots of evidence from term infants. The largest trial to date, the Torpedo study, had to stop early as people had concerns about randomizing infants to a trial with 100% oxygen as one of the possible treatments. So to talk about this study in a bit more depth, as I think it's important to know this when we interpret the results of NetMotion, they randomized infants less than 32 weeks, again to room air or 100%, but they allowed clinicians to titrate the oxygen according to a specific protocol. They wanted to recruit nearly 2,000 infants, but only managed to get 290. Unsurprisingly, as they weren't powered, they didn't find a difference in death overall, but in a post-hoc exploratory subgroup analysis, there was a possible decrease in mortality before hospital discharge in infants less than 28 weeks gestation. The infants in that subgroup that were randomized to room air, their most common cause of death was respiratory failure. So although we have to interpret this subgroup analysis with a lot of caution, there's again a possible signal here that something else might be going on and that perhaps room air isn't the best for this group of preterm infants that have different physiology to their term counterparts. This is a forest plot of a meta-analysis published in 2019 looking at all these RCTs that I mentioned in the preterm population. I put this here not to go through all the numbers, but just to illustrate the fact that all the trials kind of were estimating a different effect. And you can see that the forest plot is all over the place. The confidence intervals are really wide. And it's very difficult to kind of figure out where the true effect might be. And there's a reasonable amount of heterogeneity in here as well. So yeah, lots of uncertainty. This, just to tie up before I move on to the methods that we used, is when all of this evidence was coming out and how treatment and how practice changed. So after ResAir 2 was published in 1998 and the meta-analysis is in 2004, ILCOR changed their recommendation to say that room air might be reasonable if oxygen isn't available. And then once 2010, the next update came around, that was when it was really recommended to use room air for basically all infants, or maybe low concentrations of oxygen for preterm infants, and then titrating oxygen based on pulse oximetry if it was available. We now find ourselves at the end of this diagram where we've got certain evidence for term infants, but still a lot of persisting uncertainty for preterm infants, with lots of research already done, but no clear answers. Another way we can think of this question is kind of the Goldilocks zone. So we know that we want the infants we resuscitate to receive the just right amount of oxygen. We don't want them to be hyperoxic, where we surpass their innate antioxidant defenses, putting them at risk of morbidities of prematurity and maybe even death. We don't want them to be hypoxic because they need to perfuse their tissues. Again, we don't want to put them at risk of morbidity or mortality. We want to give them just the right amount where they've got enough to sustain their vital organ systems, but they don't supersaturate their normal antioxidant defense mechanisms. Let's think of these people running around in this field as very enthusiastic researchers that were studying this question, that are all very passionate about what the best initial FiO2 for preterm infants is. But they all had very different ideas. Some people thought maybe room air is not enough, we should try 30% and titrate from there. Others said, don't bother titrating, just give everyone 100%. Then more people said, oh, what if we start at 50% and titrate up or down? 50% is a nice halfway point. And there were lots of different titration protocols and lots of different initial FiO2s people were testing, but everyone was running in a different direction. And that's probably why we saw this, that all the studies were done in such different ways, testing different things. The meta-analysts in this study tried to group the oxygen into lower or higher, but of course there's a wide range of FiO2 within 21 to 100%. So dichotomizing it like that's probably not the most effective thing. We'll take a step away from oxygen for a second and talk about research waste. What is it? How does it apply to this question? And what are some methods that we can use to reduce research waste? Alarmingly, 80% of all research that's done is wasted, according to some claims. And a good example of this is lots of the COVID-19 research. A report from the Medical Journal of Australia of trials that were done here locally found that millions of dollars was spent on these COVID trials that were funded very rapidly. But they were either too small, collected the wrong outcomes, were redundant, done in the wrong population, or even not published. So all of this money was spent on trials and no additional knowledge was generated. There's a number of different reasons for research waste. Again, not publishing studies or not publishing outcomes. I think in this scenario, lack of coordination was the reason that we didn't have a clear answer for this question, despite lots of money spent. So the studies were all done in very different ways, and it was difficult to synthesize them. So it got us thinking about how we can reduce research waste and optimize the value of research dollars and patient time and resources in these studies. We know that systematic reviews are at the top of the evidence hierarchy, but they've got a number of standard systematic reviews and meta-analyses have a number of limitations and potential sources of bias. Analyses usually are limited to what can be extracted from study publications. We can't account for inconsistencies across study design and outcome measurements. We are subject to whatever the researchers report. So if they don't report the outcomes we need, we're not going to be able to include that study in a meta-analysis. And when interventions are complex or when there are multiple treatment options, like in this scenario, it's difficult to dichotomize things and to look at things at a granular level. One strategy that we have to combat this is individual participant data. So this refers to the raw line-by-line data that we usually source from study investigators. When we talk about IPD, it looks like what it is in the top right-hand corner, where we've got the exact line-by-line data for every variable for that infant that was collected in that study. And then we recode that data and use that to conduct the meta-analysis. A standard meta-analysis would use a table like this one, which I've borrowed from the Torpedo publication, where we've got the outcomes and the event rates for all the different outcomes, and we use that to do the meta-analysis. Essentially, if you put aggregate data in to do your meta-analysis, it's like putting a pixelated black and white picture in through the computer, so you end up with a pixelated black and white picture. With IPD, you retain high resolution information and you retain all the color. So you get all this very precise and very rich analysis that you've got a lot to work with. Another important thing is that we can look at subgroups at the participant level rather than having to rely on other statistical methods to try and figure out what's going on with subgroups. And importantly, we can look into data integrity and trustworthiness. This is another side story, but up to a third of all published research. So we know half of all research isn't, 80% of research is wasted, but a third of research might be fraudulent or fatally flawed and shouldn't contribute to the evidence base. And again, COVID had lots of alternative medicine drugs that were trialed and they were looked at to see how many might be flawed. So John Carlisle, who works at the University of Sydney, he looked at how many studies published in the Journal of Anaesthesia on COVID might be flawed. And with the raw data not available, so relying on the publications alone, they identified a small percent that were either flawed or fatally flawed. When they had access to the individual participant data, nearly 30% of all of the studies they had significant concerns about, and they concluded they shouldn't contribute to the evidence base. Some people have have made very sweeping claims in saying that we should only rely on IPD when we're considering a study to inform practice and guidelines, and we should exclude all studies that don't share their IPD because of integrity concerns. There's different things that we can do to check the integrity of studies once we receive the IPD. So Kylie Hunter, who I work with at the University of Sydney, she's come up with a tool that you can put the data through, and there's a number of checks you can run on it. And I encourage, if you're interested, you can search the IPT integrity tool, and there's a step-by-step guide of how to do this. But this is one example of one of the checks that we do. And this is a real example, not from the NetMotion study, but from another study, where on the left, you can see as gestational age at birth increases, birth weight increases. That makes sense. But on the right, someone has clearly just made up numbers. And as gestational age increases, there's no corresponding increase in birth weight. So the distribution of infants at 28 weeks have basically the same birth weight distribution as their counterparts at 33 weeks. So obviously that's a concern. This study ended up being excluded from that specific meta-analysis due to other integrity concerns as well. So now that you've humoured me and we've done our little methods side spiel, let's come back to oxygen. How does this apply to the oxygen question? We've got our researchers running around in the field. They've given us their data. We've checked that it's trustworthy. We've now got access to high resolution color pictures that we can put into the models and come up with an answer. But the researchers are still running off in different directions. So how do we pull these studies together to come up with a meaningful result? What we did was a network meta-analysis. Network meta-analysis allows you to compare and rank multiple different treatment options all at once. The example I've got on the right is from the ICOMP study, which many of you will be aware of. This was an IPD meta-analysis done at the Clinical Trials Centre on the duration of cord clamping for preterm infants. You can see here all the different lines represent a direct comparison between different trials, and all the nodes are different interventions. We can use both direct and indirect evidence in a network meta-analysis to try and come up with a ranking, so we can figure out which treatment is first, second, third, fourth, etc. So direct evidence compares or allows us to look at the trials comparing A and B. So for example, low and intermediate oxygen or low and high oxygen. But indirect evidence allows us to infer the effect of intermediate on high oxygen by looking at the other two comparisons. There's a number of additional assumptions that we need to fulfill to do a network meta-analysis, but individual participant data lets us meet most of those, so that's an advantage. So essentially that's what we did. That's what we did for the NetMotion study. It was an individual participant data network meta-analysis, looking at the best initial FiO2 for infants born less than 32 weeks gestation. So we'll move on to some of the results now and some of the other methods that we used. Our primary outcome was all-cause mortality before hospital discharge. We also looked at morbidities of prematurity and delivery room oxygen saturation trends. We included only truly randomized studies, so excluded any cluster or quasi-randomized studies because they don't work well in a network meta-analysis. We only looked at infants less than 32 weeks gestation, and if a study included infants above that cutoff, we were able to exclude those at the participant level. We grouped interventions into three: low, intermediate, and high. Low being room air to 30%, intermediate being around 60%, and high being 90 to 100%. Here's how we define the outcomes. We won't dwell on this too much. Essentially, we looked at severe IVH being grade 3 or 4, chronic lung disease with the standard definition or as it was defined in the trial, and any retinopathy of prematurity as it was defined by the trial. So we kept our definitions quite broad. All of the methods were pre-specified in a published protocol and a registered statistical analysis plan. We had an accompanying systematic review that looked at both databases and trial registries to capture unpublished studies as well, and we did find a few of those. We were able to perform all those rigorous data quality and integrity checks I mentioned before, and fortunately we didn't have any concerns of that within this data set. For those that are statistically minded, we used a Bayesian framework for this, mainly because it's the simplest way to do an IPD network meta-analysis. We did one-stage methods and had non-informative priors, which essentially means we can interpret our results like we would a standard frequentist model, plus or minus a little bit. We used random effects, and we were also able to adjust for key prognostic factors like gestational age. 13 studies were identified as eligible, and 12 of those gave us their IPD. The one study that didn't was very small and didn't actually collect data for the primary outcome. So we're confident that that study probably not getting data for that study really didn't influence the results. And overall, we had more than 95% of all total eligible participants included. The 12 studies that did give us data had 1,055 participants, and 1,003 of those ended up in the primary analysis, as some had to be excluded as they didn't have the requisite covariate data to be included in the adjusted models. Here's a breakdown of the participant characteristics overall and across the 3 treatment groups. I won't dwell on this too much, but just to really illustrate that there's not many differences across the 3 groups. So we've got a well-randomized population, and the average gestational age was about 28 weeks and 5 days. Here are the event rates for the primary and secondary outcomes. I will highlight that the mortality rate was 12%, which we were slightly surprised at. It was somewhat higher than we expected. But all of the studies were done, I guess, over a long period of time where general neonatal care has improved and the mortality rates decreased. So that might be reflective of historic practices as well. And some studies were done in slightly lower resource setting where the mortality rate was higher. So again, that might have accounted for some of the increase in overall mortality we saw compared to mortality rates that we'd expect in a less than 32-week population. Here's the network diagram. So we had 8 studies with 651 participants comparing low and high oxygen, and 4 with 352 participants comparing low and intermediate. Unfortunately, there was no studies comparing intermediate and high oxygen. I'll come back to what that means when we interpret the results, but just remember that there's no direct comparison there. And now, what did we find? So surprisingly, we found that high initial FiO2 possibly reduced mortality compared to low. There was low certainty of evidence associated with that finding, and we'll talk about why in a little bit. The odds ratio was 0.45, with a credible interval reasonably far away from the line of no effect at the upper bound of 0.86. So that was the main finding. There's also a possible effect of high versus intermediate, but that credible interval is basically crossing the line of no effect, and there's very low certainty associated with that finding. The dotted line here underneath the solid bar where my mouse is going over, that represents the prediction interval. That's an indicator of heterogeneity, which we did see as it crosses the line of no effect. I'll come back to, again, what that means when we interpret the result. For the other secondary this is another way of visualizing these results. Because we did a network meta-analysis and used Bayesian stats, we can rank the treatments in terms of their ranking probability. So there was a very high probability that high initial FiO2 was best, and a very low probability that intermediate or low were best. We've got to be careful interpreting the raw numbers, so the 97% that's highlighted in grey down here, as there's no credible interval associated with it. But it's just to illustrate the point that there was a high chance that high initial FiO2 was best to minimize mortality. Here's a breakdown of all the other secondary outcomes. I won't dwell on this for too long, but you can see in the column in the middle, we had either very low or low certainty of evidence for all of these due to a number of reasons like risk of bias. There was one finding that was statistically significant, which was that high oxygen increased SpO2 at 5 minutes by about 9% units of mean difference. But again, there was very low certainty of evidence associated with that finding. I don't have a slide for it, but we did also perform some subgroup analyses, and those did not find evidence of a differential effect of treatment across subgroups like gestational age, but we were probably underpowered for those, as normally you need a lot more participants in a network meta-analysis to look at interaction effects and subgroups. So obviously this result was somewhat surprising when we first found it, as it's in opposition to this body of work on oxidative stress. So we began thinking about why might this be happening, and why is it so different in preterm infants compared to term infants who seemingly benefit from room air resuscitation. The best explanation we've been able to find is to do with breathing effort. So Janneke Dekker's group in the Netherlands, they did a study on preterm rabbits where they either randomized them to room air or 100% oxygen. If the ones receiving room air became apneic, they were randomized to either continue in room air or receive rescue 100% oxygen. They found that those that received the 100% rescue oxygen had improved respiratory rate and decreased interbreath variability. So there was a possible explanation that maybe high concentrations of oxygen help stabilize respiratory effort in the first few minutes of life. They followed this up with a human study. This study, I should note, was included in the data contributing to the network meta-analysis that we did, but this was the only study that looked at respiratory function monitoring parameters, so I'll report the results of it separately. They randomized 52 infants and randomized them to either 30 or 100%, and they found that there was higher average and cumulative minute volumes and shorter durations of mask ventilation in the infants that received 100%. And they didn't find any differences in some markers of oxidative stress. They didn't find differences in the other clinical outcomes, but they weren't powered to do so. This is another way of looking at their results, where you can see in the light blue, the 100% oxygen arm had higher average minute volumes. I'll come back to oxidative stress now, and I think this is a point that I'd really like to emphasize. The results of NetMotion really should not and cannot minimize the large and certain body of evidence we have about the harms of long periods of high oxygen when it's not required. All of these studies titrated the oxygen in some way or form. They all did it very differently, but they all did titrate somehow. And the periods of oxygen that these infants received 100% for were very low. So this is a very messy diagram, but it's my favorite that's buried deep in the supplement. We ran out of figures and we couldn't include this in the main publication. You can see the different colors represent the three treatment groups, high being red and low being blue. You've got FiO2 on the y-axis and minutes after birth. You can see that initially, intermediate, they're all receiving about 60%. High, most of them are receiving 100 or 90%. And low, they're receiving somewhere about 21 or 30%. But after 5, 6, and even 7 minutes, there's a lot more mixing between those three groups. So really, they're only getting that initial FiO2 period for the first couple of minutes. If we separate out the low and high groups, again, you can see a lot of mixing, particularly in the high group, where most of the infants come down quite quickly. Although there's a portion of infants that remain in 100% oxygen, there's probably a similar amount of infants that remain in 100% that started in room air. So I put this here just to illustrate that it's really only a few minutes of life that these infants are receiving high concentrations. Titration is really important, and we have to be careful about how we think about this. This shouldn't negate all the work that's been done on oxidative stress. In terms of strengths, we know that this is the most comprehensive evidence synthesis to date for this population. We managed to get more than 95% of all the IPD that was eligible. So that was a key strength, as most IPDs only get about half of the data that's eligible because of a number of issues with data sharing. We were able to perform the rigorous integrity and quality assessments that I mentioned before, and we didn't have any concerns. We were able to mitigate publication bias by including unpublished evidence identified through a registry search. And we were able to extricate differences within that historic classification of high versus low. So in that meta-analysis I showed you right in the beginning, with the forest plot and the big question mark, they could only break it down into low being less than 50 or high being more than 50. We added another level of granularity to that and were able to remove any noise or crossover that existed because of that mixing. There are a number of key limitations though. Firstly, heterogeneity. So with that prediction interval crossing the line of no effect, we can interpret that as meaning it's within 95% confidence that the results of a new trial conducted in this population could find no difference or could find the opposite effect. So that's something to keep in mind. The reasons for this heterogeneity, we can only speculate, but I think it's most likely to do with the way that the studies titrated. They all titrated really differently. We tried to look into it as a subgroup or effect modifier, but we weren't able to do so because of how differently they all did it. Also, the settings differed. Some were very highly resourced tertiary or quaternary NICUs, and some were slightly lower resourced. And the populations differed in terms of time and geographical location as well. Another limitation is the risk of bias in the included studies. So you can see in this diagram on the right, domain 3, 4, and 5 are the ones due to blinding. And most of the studies couldn't blind just because of the nature of the intervention and how difficult it is to blind studies like this. So most of those studies had high risk of bias for that reason. And finally, inconsistency. So this is a concept that's unique to network meta-analysis. Inconsistency refers to whether the direct and indirect evidence agrees. If there's evidence of inconsistency, it threatens the validity of the network meta-analysis, and it needs to be identified before the results can be truly interpreted as confident. With a non-connected or disconnected network like we have, we can only do some checks of inconsistency. The ones that we did do didn't reveal any evidence of inconsistency, but the other statistical tests require a connected network. So because we couldn't really confirm that there was no inconsistency, we downgraded certainty of evidence by 1 because of this. So this is the most common question I've got when we've presented these results, of course. So what do we do now? We're clinicians. Great, you've told us all about the stats. What should I do in my day-to-day practice? I think this is a really difficult question to answer because of the limitations of the evidence. It's the most comprehensive evidence we have to date, but it's not very certain. And there's very large ongoing trials that are just about to complete. So what should we do in the meantime while we're waiting for those results? If we turn to ILCOR, so the International Liaison Committee on Resuscitation, they're the peak body that forms the consensus on science and treatment recommendations that trickle down into all the national guidelines. Prior to NetMotion, the treatment recommendation was suggesting to start with lower concentrations of oxygen, being 21 to 30%. But there was a weak recommendation and very low certainty of evidence associated with that. In their 2024/2025 draft update, which I believe is still out for public comment, so you can log on to the ILCOR website and write your comments and look at the evidence if you'd like to input. They've interpreted not only NetMotion, but an updated ILCOR-specific meta-analysis. And they've determined that it's reasonable to begin resuscitation with 30% or more in infants less than 32 weeks. But again, that's a weak recommendation with low certainty of evidence. They've concluded that for infants 32 to 35 weeks, there's insufficient evidence to make a recommendation. But I think very importantly, they've highlighted that there's so much uncertainty in this topic that it's reasonable to study a full range of oxygen concentrations in a research protocol. So previously, the issues that torpedo study had with recruitment, hopefully we can overcome those now as we've got confidence from the peak treatment recommendation forming body that it's reasonable to study a complete range of oxygen concentration. That quite organically leads me to what's happening now and what studies are upcoming. So there's at least 5, last time I ran the search, that are underway. The largest is Torpedo 3060, which has just finished recruiting, and we're eagerly awaiting the results of that study that recruited nearly 1,500 infants. There's also the Hilo study, which is also comparing 30 versus 60, being run by Prof. George Schmolzer, who is aiming to recruit 1,200 infants. And last I checked, they were just over halfway. They might be even further into recruitment now. And there's 3 other smaller studies. We're planning to synthesize the results of these in a prospective meta-analysis where you identify the studies as eligible for inclusion before the results are known as a way to mitigate publication and other bias that will hopefully be available in a couple of years' time. We'll also update the results of net motion once all this data is available. This is what the network diagram will look like with all this updated evidence. So we'll have nearly triple the sample size, but only looking at high versus low and high versus and intermediate versus low. There'll still be no ongoing trial comparing intermediate and high. And that's a key gap, I think, and I'm really hoping a study will come out that examines that comparison. This is just a study kind of outlining the timeline of when we might expect this evidence to be available. We're working hard to get it out as soon as possible, but we're aiming for kind of end of 2027, maybe, for promotion. And we'll also be able to comment on some neurodevelopmental outcomes in the long term with the evidence from HILO and Torpedo 3060. Take-home messages. I've done a lot of talking about the statistics and stuff, and I recognize most of this audience are clinicians, so they want to know what they should do in their day-to-day practice. I think based on the results of net motion, we can't make a firm, certain treatment recommendation, unfortunately. We've got a signal that high initial FiO2 possibly reduces mortality compared to low in infants less than 32 weeks, but we need a lot of caution when we're interpreting that result because of the limitations like heterogeneity and risk of bias. There's lots more evidence about to emerge in this space, so I think before we can make a firm, strong treatment recommendation, we'll have to wait for those results. I think separate to this topic, this is a great example of how we were able to use individual participant data and network meta-analysis as a way to reduce research waste. All of this new information on this topic was generated without needing to randomize an additional participant or spend much more money on large randomized controlled trials that take many years and a lot of resources and effort to run. All we had to do was really pay for the statisticians. So this is I guess a good example of a way we can reduce research waste through collaboration, data sharing, and using these methods. I'd like to thank a lot of people. I borrowed lots of these slides from Prof. Lena Seidler and Dr. Kylie Hunter, who I think are online today, as well as the Next Gen Evidence Synthesis team at the University of Sydney. I want to thank the steering group, particularly Lena, Prof. Julie Owie, and Prof. George Smolzer, who were pivotal in the conception, design, and conducting of all this study, and also the trialists who all very graciously trusted us with their individual participant data, and were all very active members of the collaboration inputting on all the results along the way. That's the end of my talk. Thank you all for your attention. If you have questions or want to work on an IPD, feel free to email me, or my Twitter handle is there, and happy to talk about any questions that you might have now.
Thank you very much, James. And thank you to you and Kitai for starting the talk. Excellent talk as usual. And I have to tell everyone online that it was a very lucky day when you sought me out to hunt for a research project. You are amazing. And for everyone here, he is still an intern. All right. So, okay. So if you have any questions, please put it down on the chat pane for James to answer. But maybe I can kick it off. How would you suggest that we do an RCT of 60 versus 100%? I'm not sure, I joined late, I'm not sure whether you went through it, but we had the greatest difficulties in recruiting against the tide for the first torpedo study. No one would join us because of the 100% arm. 60% is still considered quite dangerous, quote unquote, by clinicians.
Yeah. I think that's a good question. I'll start with, I think it's reassuring that ILCOR in their updated recommendation have recognized the uncertainty, and they've said that the full range needs to be studied. So hopefully that reduces some of the anxiety about randomizing participants to higher concentrations like 60 or 100. I think pragmatic study designs are needed here. Methods like cluster trials we didn't include in the initial net motion update, although HILO 3060 is a cluster trial. I think those methods might need to be explored as ways to improve recruitment and get answers here where it's very difficult. All studies of resuscitation, it's difficult to get consent. often we need to pursue alternative modes of consent like consent waiver. So I think pragmatic designs or even adaptive designs need to be looked into.
Thank you. Do you think that when we plan for an RCT that we should include the evidence synthesis team as part of our planning? I know what you will say.
Yeah. Yes, I think so. Particularly if the study is going to be involved or there's potential for the study to be involved in prospective meta-analysis. The main thing that the evidence synthesis team can do at the design stage is ensure the data is collected in a way that it's usable by evidence synthesis down the track. So it doesn't have to change the design or anything of the study, although we can provide advice if required, but it's mainly ensuring all the outcomes are measured at the same time points. And that's something we've been able to do with promotion. So I know, for example, Torpedo 3060 and Hilo, they were able to collaborate at very early stages to ensure their data sets are going to collect the same outcomes in the same way. So that's another way that we can reduce research waste as well.
Absolutely. I think evidence synthesis needs to be integrated into the planning of any RCT. Dr. Sam from Singapore has raised his hand. Hello, Sam. You're looking younger every day.
Hi, hello. Yeah. Thank you. Yeah, James and Julie, excellent. Talk lots of information, more than 80 slides nearly. Anyhow, I'll share that the first Torpedo 1 trial, Julie, you may remember it was planned in Garden Hotel in Singapore several years ago.
Many years ago.
Many years ago. Unfortunately, Singapore Ethics Committee said, how can you resuscitate a baby with air? Whereas Australians were concerned with 100%. Unfortunately, we couldn't take part in the study. Okay. Now, my question is, some of them, particularly from UK, they are recommending database based studies. They say you can randomize and get a quick result, reasonably quick, whereas randomized controlled trials, particularly more than 1,000, sometimes may take 5 years plus. So what do you think about the information they bring, and now they put AI into it, and sometimes we get results contrary to usual practice, and whenever you put AI these days it gets published even in good journals. Are they misdirecting us?
Yeah, I think that's a good point. I think that highlights the data integrity question, and that's another advantage of IPD, that we can do more specific checks to check the study hasn't been adulterated or the data hasn't been adulterated by AI. It's not a 100% science. It's all very new. So there's still, I think there's ongoing work that Kylie might be online somewhere, but she's working on other ways that we can check all of this data. But yeah, it's very difficult you're right, it's very difficult when AI gets involved. I think what you were also saying though about integrating the outcome collection into databases, that's a great idea. And I think that's something that's starting. I know of a few examples in Australia that they're doing that now. I think the aeroplane study based in Victoria is doing that. So that, yeah, more ways to reduce research waste and improve research integrity, I think.
Thank you.
Thank you, James. There's a question from Charles asking whether titration saturation targets for preterms are likely to be the same as term infants. Yeah, that's an excellent question. That no one has any idea, I think. There's some evidence similar to the Dawson curves that say maybe the evolution is about the same, but it hasn't been specifically studied. There's the ongoing OptiStart trial by Vishal Kapadia in the US is looking at different oxygen saturation targets as an intervention that people will be randomized to. So that might give us more clarity there. We're also planning a Cochrane review on titration as a specific intervention. And it's something I didn't really get into today because I think it is really its own separate topic. But I expect that we're not going to find much in that review, and that there's going to be no real hard evidence informing the titration targets, at least in the delivery room. So Charles, when we looked at RCTs, 8 RCTs for the babies who were less than 32 weeks, Those who didn't meet an SpO2 of at least 80% by 5 minutes had increased risk of death and intraventricular hemorrhage. So what we are doing now is targeting healthy infant saturations regardless of gestation. We don't know, as James says, the implications of the differences in gestation on these oxygen saturation targets. And hopefully with this IPD and this collaboration, we can find out what works best for babies of different gestations. It's a nightmare targeting SpO2s anyway. Changing FiO2s when you're doing the respiratory support and the stabilization. Oh my God, you need to be an octopus and have 8 hands or something. So it's a work in progress.
I think another thing that I didn't mention is, I know we were just talking about AI and the risks of AI, but automated oxygen control is very common in the NICU environment now. And there's some work about automated titration in the delivery room. So that might be another frontier that makes this whole titration process a bit more streamlined as well.
Absolutely, from Peter Dargaville's group in Hobart. So Dr. Krishnamurthy has said that the NEOPROM trial, which did an IPD analysis, showed decreased mortality among extreme preterms maintained at higher oxygen saturations. Do you want to comment on that? This is during the NICU study.
Yeah. So I think the difference with net motion is that it's just that initial period. And if we go back to that, the graph I showed before, it's only really a short few minutes that they're getting high initial FiO2. NEOPROM's another really great example of like collaboration and reducing research waste through IPD, but to answer a slightly different question. So I wasn't involved in NEOPROM, so I can't comment on it much more. But yeah, I think the difference with net motion is that it's just a very short period of high oxygen that we're giving.
The NEOPROM trial looked at the boost studies about oxygen saturations while the infant was in the NICU, as you said, Dr. Krishnamurthy. And there were different risks and benefits to different oxygen saturation targetings. There might have been decreased risk of death, but an increased risk of conditions such as ROP with higher oxygen saturations. So I think what we have to be aware of is that the preterm infant changes, and the change can be very rapid within the first few minutes of life. And then after that, as they evolve and survive, their oxygen needs will change even further. And we need to find out what this need is. So thank you. Okay, yep. All right. There are no other questions. If there are no other questions, I am not sure whether this talk is recorded, James.
I am not.
See the little record button, but if that's possible, if you wouldn't mind providing a PDF of your slides so I can upload it to the shared Dropbox. If anyone has any questions for James or his team, Kylie, Lena, please feel free to contact us. Contact him. He's given you the address. And if you're interested in IPD work, it can all be done like online, isn't it, James? You don't even actually like in human form. You could be a bot for all I know.
Yeah.
Right? So if there are no questions, well done. That was an amazing talk. Thank you. And sorry for turning up late. And any questions, I think James would be very happy to answer you.
Yeah, happy to be contacted.
Thank you, everyone. And for those of you in Queensland, good luck and stay safe. Bye. Bye, everyone.